So today we speak about ischemic heart disease, and as you know from fourth year, we have stable period of ischemic heart disease that is called stable stenocardia, post-infarctive cardiosclerosis, etc. And we have unstable period of ischemic heart disease that is called in general acute coronary syndrome. Acute coronary syndrome is divided into two main subgroups, with and without ST elevation. If the patient has acute coronary syndrome, wait a moment, acute coronary syndrome without ST elevation, the patient has incomplete coronary blockage. In this picture you see a vessel, thrombus inside the vessel, and atherosclerotic plaque that is ruptured. This is the place of rupture of atherosclerotic plaque with thrombus formation. If the patient has incomplete blockage of coronary artery, the patient will have ST depression as usual, and as the outcome, the patient will have two variants, unstable stenocardia or Q-negative or microfocal MI. If the patient has acute coronary syndrome with ST elevation, it means that the patient has total occlusion of coronary artery. In this picture you see atherosclerotic plaque, ruptured atherosclerotic plaque, and total occlusion, obturation of coronary artery. As a result, this patient will have a MI, microfocal or Q negative, or macrofocal, or it's the same as Q positive. It's important for us to differentiate these two conditions, acute coronary syndrome with and without ST elevation, because our treatment procedures depend on this dividing. During MI progression, myocardium of the heart pass three stages. This is the normal ECG. Then we have zone of ischemia as the initial zone, and on ECG it's manifested by coronary T wave. What is coronary T wave? It means that T wave has three signs, three criteria. All of these criteria should be present to make a conclusion about coronary T wave. First criteria, T wave is negative. Second one, it's symmetric. And the third one, sharp T wave. On this picture you see all of these three criteria. It's the zone of ischemia. If the patient has continuous zone of ischemia, this zone goes to zone of injury. It's the second zone at the center of myocardium that was ischemic. In case of zone of ischemia, we have second ECG criteria of MI, ST elevation. And if we have continuous ischemia, zone of injury goes to zone of necrosis. On ECG, we have third sign of MI, that is pathological Q wave. What does it mean, pathological Q wave? Q wave is more than 1/4 of R wave in the same lead as Q wave. More than 1/4 of R wave. It's the first variant of pathological Q wave. Increased amplitude of Q wave. And the second possible criteria of pathological Q wave, that pathological Q wave is widened more than 0.03 milliseconds. You should know that zone of necrosis is the irreversible zone. If the patient has zone of necrosis, as a result, the patient will have scar. Scar is the outcome of necrosis. If the patient has injury, the reversible zone. It can go to ischemia, and ischemia goes to normal myocardium. That's why it's important to restore blood circulation if the patient has ST elevation. That's why we perform thrombolytic therapy or revascularization methods for these patients. During MI progression, we have 4 periods of MI. Of course, you should know it from previous years also. 4 periods: very acute, subacute, and scar information. In case of very acute period of MI formation, we have only 2 zones: ischemia and injury. In case of acute period, patient will have all zones: ischemia, injury, and necrosis. If the patient has already subacute period, there are 2 zones are present, but another than during initial phase: zone of ischemia and zone of necrosis without zone of injury. And scarring period is the presence of only zone of necrosis. That's why we have typical ECG criteria for each period of MI. On this picture, upper line includes 4 periods for macrofocal MI: very acute period, acute, subacute, and scarring. And second line is the ECG progression in case of MI development, in case of microfocal MI or Q negative MI. It's the same. What about duration? You should know that very acute phase lasts up to 6 hours. Acute period up to 2 weeks, 14 days. Subacute period up to 6 weeks, and period of scarring is up to 6 months. It means that we discharge the patient from the hospital at the end of acute period, not at the end of scar formation. It's important for the patient that rehabilitation should be continued up to half of the year. And what about ECG changes? In period of very acute, we have only ST elevation without pathological Q wave. Theoretically, if we restore blood circulation completely, MI will be not developed, theoretically. In case of acute phase, we have zone of necrosis, as you saw on previous slide. That's why we have pathological Q wave. We have zone of injury. That's why we have ST elevation also. And that's why we have pathological Q wave, ST elevation as 2 signs of acute period of MI. Subacute period. In this period, we don't have zone of injury. We have zone of necrosis and zone of ischemia. That's why on ECG we have pathological Q wave and coronary T wave. And period of scarring is characterized by the presence of pathological Q wave only, without ST elevation, without coronary T wave formation. You should know it. You should know this table, of course. Second moment that you should check for its localization of MI. We make a conclusion about localization of MI based on leaks that contain pathological moments. And what about localizations? Uh, we use all of these standard 12 leads, and we can use additional leads. A V for right, as we said previously, V7, V8, V9. On this table, you see that if we see changes on first standard lead, it's the left side of the heart, it's the left lateral wall. If we see changes in second and third lead, it means that inferior wall of the heart is affected. Fourth leads, the same. AVR is not used in determination of the localization of MI. AVL is the lateral wall again, AVF inferior wall again. What about chest leads from V1 up to V6? V1, V2, interseptal wall, interventricular wall. V3, V4, anterior wall of left ventricle. V5, V6, lateral wall. What about additional leads? V4 right, if we suspect MI of right ventricle. V8, V9 for affection of posterior wall of left ventricle. It's the table that includes all leads. For example, I repeat that we can speak about clinically significant changes on ECG if we have ECG changes in two neighbor leads as a minimum. For example, if we see some changes in first standard lead, it means if we suspect lateral wall affection. We should check for AVL, V5, V6. One lead as a minimum should contain the same change. For example, if we found something in AVF, we should check for the same changes in second and third leads. Next few slides, you will see examples. How can we determine the localization of MI? On this slide, you can see ST elevation in V3 and V4. It means anterior wall affection. On this slide, I saw at first AVL, ST elevation, yeah? We remember that neighbor leads are V4, V5 and V6, yeah, the same. We have ST elevation in V5 and in V6. It's the lateral wall involvement. In this case, second standard lead, third, and AVF. It means we have inferior wall affection. In this case, V1, V2. It means intraventricular septum involvement affection. In this case, we have no ST elevation, but we see high amplitude of R wave in V1 and V2. It's abnormal criteria. it's the indirect sign of posterior wall involvement. That's why in this case we should record additional leads V8, V9. And in this case we'll find typical ECG signs for MI, ST elevation in these leads.